Well, hello everyone. It is 3 o'clock, so let's go ahead and get started here. Welcome to our session today. My name is Dr. Rachel Vreeman. I'm a pediatrician and a global health services researcher. I do research work related to children and adolescents who are growing up with HIV in sub-Saharan Africa. And it's my privilege to be the director of the Arnhold Institute for Global Health at Mount Sinai and the chair of the Department of Global Health and Health Systems Design at the Icahn School of Medicine at Mount Sinai. Our group has launched this webinar series related to COVID-19 and global health. It's been our great privilege to create a platform where we can discuss not only what's happening here in New York City and in the United States with this pandemic, but also to bring a global perspective on it. And interestingly, in my thinking, part of how we really consider this pandemic with a global perspective is to really understand more about how the public hospital system and the public health systems within our country, within the United States, function, and especially to consider the stories and reality of how they have been impacted in the middle of this pandemic. So I'm incredibly excited for this discussion today, where we're going to talk about COVID-19 care in the New York City public system. So really a global lens on our very local pandemic right now. As a starting place for our discussion, for those of you who are joining us, we are going to have a time where we take questions and the panelists will respond to them at the end. Please feel free to type your questions into the Q&A box that's at the bottom of your screen. We'll review those and pull up some questions that we can answer at the end, depending on where our conversation goes in the meantime. But please feel free to put in questions to that box at any point. And so with that, we'll go ahead and get started. Again, I'm really excited and really honored to welcome our panelists today. We have two physician leaders from Elmhurst Hospital. I'm going to talk about their roles, but who really do bring with them both the expertise and the true frontline perspective on what it has looked like to address the COVID-19 pandemic in New York City, and particularly within the public hospital system. So joining us today, we have Dr. Joe Massey, who is a physician, educator, and author who's based in Elmhurst in New York City. He's a professor of medicine and a professor of environmental medicine and public health at the Icahn School of Medicine at Mount Sinai. And since 2017, he's been the chair of the Department of Global Health at Elmhurst Hospital, where he previously at Elmhurst served as the director of the Department of Medicine from 2002 until 2017, and the chief of infectious diseases from 1999 to 2002. In addition to these leadership roles, which are very significant, Dr. Massey served as the director of the AIDS service at Elmhurst from 1986 through 2002. So he's really renowned for his work as a clinician, as a researcher, and as an educator in infectious diseases, in HIV/AIDS, and in emergency preparedness. Among the 7 books that he's written, they include The Outpatient Management of HIV Infection, a book on bioterrorism and hospital preparedness for that, and most recently, a book all about Ebola, describing clinical patterns and public health, which is, I think, again, a critical expertise when it comes to facing this new pandemic with us right now. So we're welcome and excited to have Dr. Massey. And then we also have with us today Dr. Joan Curcio, who is a graduate of the Ross University School of Medicine and who completed her residency at the Mount Sinai School of Medicine at Elmhurst Hospital Center Internal Medicine program. She stayed on there as the executive chief resident and then joined the faculty as a hospitalist and has really worked her entire career at Elmhurst Hospital. Her primary focus and interest has been how to optimize systems to ensure adequate healthcare access for vulnerable communities. She became the division chief in internal medicine in 2006, where she's built the largest division at this very large hospital. She has, within that, her responsibilities include managing 200 inpatient beds, the training of residents, a physician advisor program, and most recently, the medical consult service. Dr. Curcio has taken on a role directing the inpatient services, as well as directing an observation unit as well. And since 2017, she has served as the Associate Director of Medicine for Elmhurst Hospital. She's been recognized as Elmhurst Doctor of the Year and one of the American College of Physicians' top hospitalists. So again, welcome. We're really honored to have you with us, Dr. Curcio, and also Dr. Massey. Now, as I frame this discussion, I wanted to note we're particularly excited to engage in this discussion from those of us from the Arnhold Institute of Global Health with our connection to the Elmhurst Institute for Global Health as well, because we've been working closely over the last month and a half, 2 months, with Dr. Massey and his colleagues at Elmhurst in specific response to the pandemic. And out of that, we've launched together something we're calling Cure-19, which is a COVID-19 focused research partnership, a research unit between the Arnhold Institute for Global Health and the Elmhurst Institute for Global Health, and using that research platform to really try to respond and support the needs of what frontline physicians and the entire healthcare teams at Elmhurst are experiencing. So we've had the opportunity to dig in and hear some of these stories about what you've been facing at Elmhurst. But I thought maybe it would be a helpful framing and introduction to our talk today to first start by explaining to those who are joining us and listening today a bit about the New York City health and hospital system, who it serves, and what it is that makes Elmhurst Hospital, which is a part of that system, so special. I think maybe Dr. Massey, should we start with you?
Sure, yeah. The health and hospital system in New York is the largest public hospital system in the country, and it includes 11 acute care hospitals. Elmhurst is one of them. It also has chronic care facilities, regional clinics, et cetera. Elmhurst itself is a large, but maybe not large enough hospital for the size of the community that it serves. In Queens, we're located in Western Queens, as many of you know, and Queens has lost a lot of hospitals over the last 10 years or so. Elmhurst has worked to take up the slack. We have a patient population that is about 35 or 40% uninsured. It's a very diverse patient population. In fact, this is the most ethnically and culturally diverse square mile on Earth that we're in. There are 190 different languages spoken in the zip codes that go right around the hospital. And as a reflection of that, as many of you who may have rotated here know, we have fairly sophisticated systems of interpretation. It went from physical interpreters to audio interpreters and now to video interpreters. And it is a challenge, but it's also a very rich experience here. We do see patients from all over the world and every cultural background. And in my specialty in infectious diseases, that's been particularly poignant. And we are one of the centers in the United States for imported infections from other parts of the world for that reason. We're affiliated with Mount Sinai. We've been affiliated with the medical school since the 1960s, and all the physicians here, attending physicians, and all the physicians in training are on Mount Sinai's staff. We're very proud of our attending staff here in the Department of Medicine. We have, in addition to Dr. Curcio, who you just heard about, we have the usual divisions in the Department of Medicine. In infectious diseases, we have a somewhat enlarged division because of the large AIDS population that we've had here. We've gotten additional resources to provide attending physicians for them. We have one of the largest AIDS programs in the country. We're following about 1,500 HIV/AIDS patients in our clinic, and it is a very effective clinic. They have a very high rate of viral suppression, and we're very proud of that. We have lots of different hardworking people who work in the clinic, and I wish there was time to make note of all of them. over the years here, we've gotten, because of this international exposure that we have locally, perhaps, we've gotten involved in international projects in Ethiopia and in Russia, particularly focused on HIV/AIDS care. So maybe I should stop there and consider that a brief overview.
Sure, I think that's a terrific overview, and especially considering the context of your expertise in infectious diseases within the group and the population served by Elmhurst. I remember you telling me about how your strategic location between the major airports even also provides a very particular exposure in that way, in terms of people potentially landing from around the world, and this hospital being the first point of response there.
That's right.
Absolutely. Dr. Curcio, is there anything you wanted to add to that description, or things that you found to be really particular to the population served by Elmhurst, or how Elmhurst is serving patients in that regard?
Yeah. You know, of course, I would echo everything Dr. Massey said. If you look very specifically just at our zip code, and of course our catchment area is really 9 zip codes surrounding, the 11373 has about a population of just under 100,000. It's pretty equally split into a third of US-born citizens, maybe a third naturalized, and a third who are undocumented. So it really, separate from the cultural diversity, there's really a big financial diversity across our patients. And we tend to get more of the undocumented, uninsured, or underinsured, just because people would preferentially go to a place where they have private doctors who can direct them in. So we wind up really taking on mostly the vulnerable population. And that definitely impacted, of course, how things unfolded here.
Sure, absolutely. Which, you know, of course, Elmhurst was arguably among the hardest hit, if not, you know, among the very hardest hit of the public hospitals in New York City, and arguably one of the most affected communities globally, especially when you consider, you know, the true size of the population in that way that you're serving. Can you tell me a little bit more, or maybe some stories from what that's looked like from your clinical perspective, Dr. Curcio, and then we'll turn to Dr. Massey after that.
Sure. So at our baseline, we're a pretty busy place. We typically have, you know, 130 general medicine beds, along with 35 what's more of a step-down level bed, and 8 ICU. We run 110% census year-round, so we're used to busy. That's not, you know, anything different. What happened here clinically, we saw a really, really rapid increase. We went over a period of 4 to 5 days from our normal 110% census up to about a 250% census.
Wow.
And we went from, you know, we took over multiple floors. We went from managing 130 general beds to about 180 general beds, along with maybe 60 ICU beds. So it was just a very steep climb in a 5 to 7 day period. And along with that, we still had another 80 to 90 people admitted that we were trying to manage in the emergency room. So it was really just an explosion. Why it got to that point specifically at Elmhurst as the epicenter, you know, I think there were a lot of community factors that are involved. So of course, our general population maybe didn't have the same understanding of the disease and the potential of going to an emergency room to seek care if they weren't particularly sick, or people who were seeking testing maybe when they weren't too sick or weren't sick at all. We had large numbers of patients showing up to do that, where in a more savvy, educated population, people might have thought, I don't want to go to a place where everybody is sick in the middle of this contagious situation. So we had a lot of people showing up who maybe got exposed just through that crowding. And then when we were seeing people who were moderate, lower risk, or probably positive, who couldn't be kept here, didn't need to be kept, we were sending them home to self-isolate. So again, we're sending people to homes where there's a greater density within each individual home. So for our area, the average apartment holds 3.3, 3.5 patients, where the New York State country average is 2.6. So, and I'm sure it's an underestimate.
Yeah.
So people are going back to single room apartments where 5-10 people are always around and trying to self-isolate. That wasn't going to happen if they even were truly understanding what it meant. So I think that helped to cause a little bit of our explosion, and the population, again, not having the ability to decide not to work. We have a lot of people working in service industries who weren't going to stop going to work until they absolutely had to, if they were sick.
Yeah.
So from our end, we just had this tremendous explosion very quickly. Everybody had to escalate the level of care, of acuity that they were used to taking care of. So we have a 35-bed unit that normally houses, step-down level patients managed by 2 hospitalists that became a 35-bed ICU overnight. Everybody more or less upped their patient census by 30 to 50%. Their acuity levels went up. People who hadn't really been looking at vents in some time were suddenly trying to manage vents. And of course, we were dealing with a disease that no one knew how to treat.
Yeah. How can you tell me a little bit more about what that looked like for the physician teams that you're managing and trying to pull together to suddenly handle so many patients who are so sick, and with the same number of people on your physician teams, but or maybe even less if people were getting sick and so on.
Yeah, we were fortunate not to have, we had a few physicians get sick. We were fortunate that it wasn't a very large number. But immediately taking care of our normal population, we would have 6 attendings on a general surgical area. So we were able to double that and go to 12 physicians, each managing a team with a resident and an intern, and add 2 additional teams. So we immediately went from 6 kind of attendings managing the cohort of residents to 14 attendings on the floor, each with a team managing up to 20 patients. So that was a huge jump. These are all people who have been working in a hospital for a while. They're used to volume, but not typically used to 10 or 12 new patients a day coming in continuously. On our critical floor, our intermediate floor, which became an ICU, we had to leave them in the team size they were and just add additional fellow and critical care support. So we wound up with more or less 4 attending level people managing this 35-bed ICU. We were dealing with PPE. In the first days, that was confusing just to get everybody up to the level of what they needed. And then, we're used to, of course, very stringent PPE practices. You don before entering, you doff when you leave, you only see 1 patient in between. Suddenly we're changing floors to be entire units where, you don before entering and you're going patient to patient without changing gear. That was a mindset that was difficult. It was hard for people to change the practices that we've drilled in so much over years to be stringent to. And along with the volume, of course, there was the acuity. People who were fine at 9 o'clock in the morning when you went back to see them at 11 o'clock in the morning were now having labored breathing or decompensating. We were continuously escalating levels of oxygenation. We were intubating on general floors. So again, things that, as an internist, I was not really prepared to be suddenly managing vents on a general floor.
Sure, absolutely. Dr. Massey, anything you want to add in terms
Yeah.
of what it looked like seeing this pandemic sweep through your hospital and your community as well?
Yeah, we also got a lot of help. We got volunteer physicians really from all over the country, some of whom had worked here before, some of whom hadn't, volunteer nurses from all over the country, and military medical people from all 4 branches of the military. And each of that type of provider served a really important role. In fact, they've gotten the military personnel to extend their time here another few weeks. And they were especially effective in the intensive care unit patients. And I can't say enough about that effort. Also, because we're a network of 11 hospitals, there was this capacity for transferring patients to hospitals that had not been hit quite as hard. So there were days when 30 patients would be transferred from here to one of the other Health and Hospitals, and the Health and Hospitals Corporation also stood up a 200-bed hospital on Roosevelt Island that they rapidly filled with patients who were transferred. Now, as Joan said, some of these patients were difficult to evaluate in that they would become unstable so very quickly. So for that reason, we still have many patients here because we weren't comfortable transferring patients out as we might have been with a different sort of disease. But I can't say enough about the additional resources that we were provided with. I think if we weren't part of a big system like we are, it would have been even worse.
Excellent. Can you maybe share more now about the current situation in terms of how clinical care delivery is evolving and beginning to return to something a little closer to a new normal, perhaps we might call it, not quite normal, of course.
Joan, did you want to start with that one?
Sure. So for the last 2 weeks, our volume has consistently gone down. First, the non-critical, and then slowly the critical care volume is going down. We have returned to somewhat normal team sizes. We've maintained this extra presence of attending physicians, managing these teams, but they're down to a very comfortable level of maybe 10 patients, which is nice for them and great for everybody. Step number 1 in terms of structural changes was really to start to get a clean unit. This is going to be a daunting task across our hospital to reorient to these different types of units now. And I'd imagine at smaller hospitals, it's going to be even more challenging. So we were first able to shut down and then cycle clean one floor and open up a space for patients who are really deemed COVID negative upon presentation, to be able to take, we are a level 1 trauma center. We had to turn traumas away in the middle because you didn't have a safe place to put somebody after treatment, so they would stabilize and move out. So we do have our first clean unit with a step down space available. And that was good for about a week, where we were triaging patients, and there weren't a lot of theoretically non-COVID patients coming in. What we've seen in the last 72 hours is an uptick as people do start to come back from the community with people who are presenting with no COVID type issues, but we can't take the assumption that they're COVID negative. They still need a full evaluation. They still have to be tested before we could put them in these clean units, because we don't want to endanger the other patients. So this is going to be a real logistical difficult task. We are looking to open what we're calling a PUI unit. We have a previously unused unit that was psychiatry back in the day that's being refitted, so we can have all individual negative pressure rooms and put all these questionable or probably negative patients there in a transitional period. That brings its own complications of staffing, particularly from the nursing and clerical side. The doctors are a little more movable. But that's going to be essential. And again, I could see just today it's revving up the number of patients coming in that are probably not COVID, but have to really be cleared before they can go somewhere. If we pick up back to our previous, 110% census with non-COVID patients, this is going to be a continuous challenge. We have exposed to ourselves more some issues that we knew existed. Coverage at certain times of the day, maybe overnight coverage wasn't quite as strong as we would have liked, or weekend coverage wasn't as strong as we would have liked, things that we all would have changed if we could. I think that this has helped us, as Dr. Massey mentioned, all this additional outside help, volunteer staff. We've really been able to create, as the census went down, more of an ideal staffing that I think will be great to show the benefits and the need going forward. And I think we're going to get support to keep that kind of staffing.
Sure.
Yeah, if I could just add, I think there are questions that were created by all of this, some very serious questions. For example, the patients who didn't come to the emergency room who would otherwise have come because of crowding, et cetera, what happened to them? How can we pick up their medical care now? Patients who were scheduled for clinic appointments, we scaled back all of our clinics and set up televisits. And that's fine for many patients, but it's not perfect for everybody. And we have to figure out exactly how to bring them back. And there was kind of a puzzle to this, and I wonder if Sinai has had that same sort of puzzle, and that is that while there were so many COVID patients coming in, we weren't exactly sure where all the other patients were going, or were they really just staying home with the same conditions that they would normally come to the hospital for. So we have some plans now to try to interpret some of these things, and I think when you've been through an experience like New York City has been through, you have to take a really, really short time to catch your breath and take on what problems now have been created by that and have to be solved. And that's what we're going to start working on and have started working on already.
Sure, absolutely. And I think it's interesting. Just this morning, I was on a call that was with the chairs of the Mount Sinai group, and absolutely, they're asking the same questions. And as they consider, how to and when to reopen which services and what that looks like and how to do that safely, the same questions of where, what has happened with these patients that we would usually see. Where are they? Did they just stay home? Did they somehow go elsewhere? How are they doing in the meantime? And those other impacts of this pandemic that we see. I think to your, I heard you just saying there, it creates these additional questions and these things that we really do need to try to look at and answer in this. I would love to hear you talk a little bit more about why you think it's so important that research is generated out of this and out of a place like Elmhurst. In my mind as a researcher, when I think of questions, I think of research, and I think that really, we of course also think of other kinds of research in laboratories and so on, but of course the things you're talking about are also research questions.
Sure, yeah, there are certainly many, many questions for us to look at systematically now, starting with what does this say about hospital capacity? What was the actual impact on the people who worked here? And I don't want to fail to mention how traumatic this has been. Certainly for younger doctors, interns and residents who were expecting to complete a training program. We're suddenly pressed into service for this. And I think for some people that is a really positive thing. For some people, it's a really negative thing. And that's another element to this that we can't forget about when we start studying the impact. But we have uncovered many medical issues in these patients that have to be explored further. One project that we've discussed with the Arnhold Institute and you, Rachel, is to look at the meaning of the positive chest x-rays that almost all of these patients had. We had many patients who came in with no respiratory symptoms and had 5-lobe pneumonia. So what exactly is the natural history of that? Should we be thinking in terms of long-term follow-up, almost a 9/11 type project for those patients? So we're strategizing some to answer some of those questions in a somewhat smaller group of patients, and then to decide how we can explore it, much more broadly than that. We also have found some odd medical facts about these patients. The high rate of renal failure, for example, that is not completely understood yet. The really extremely high levels of various cytokines in these patients and what it meant and how that both impacted the course of the disease and what it may mean for future attempts to treat. Treatment, unfortunately, has been a confusing morass of drugs that were reached for because of the incredible severity of all of this, and now we're trying to figure out what worked and what didn't work. And my own suspicion is the drugs that we're talking about these days will not be at least the only drugs that we're going to be using down the line. So name a facet of clinical and bench research, and there is an important area in this epidemic that has to be divided up and looked at. And that includes the basic sciences as well. We're looking, for example, at what the meaning of these seemingly spontaneous bacteremias has been. Where do those bacteria come from in these patients, and what can be done about that? What's going on with their mucosal immunity to allow that to happen? So now we have many, many more questions than we have answers. And luckily we're connected with a large academic center, and we can begin to make our own contributions to finding those answers. But there's a lot. I could certainly go on and on about
Sure. How I'd be, of course, I can kind of guess how you might answer some of this, but how do you envision this as a global health kind of research program in that way? Like, why are these actually global health questions and not just local Elmhurst questions in that way? Or kind of what can Elmhurst tell the world?
Yeah, I think the sheer dynamics of this, New York is by far the hardest hit area of the world, and Queens and Elmhurst and South Bronx were the hardest hit parts of New York. Certainly every part of New York was hard hit. Figuring out exactly why that is. We have communities here that may have been at greater risk. We have to determine whether there are ethnic risk factors for this. As most people know, this has not yet hit Africa very hard, and it has skipped many parts of the world so far, at least, and it's not really well understood why that is. Is that a genetic determination, or is it something else about diet or something else in the environment? This is clearly a global outbreak, and to state the obvious, and I think figuring out why it played out in various ways in various places is going to be really important. In the United States, we have not seen the same pattern as was seen in Western Europe, in China, and in Korea, where there was a peak followed by a fairly rapid drop-off in the number of cases. In the United States, there's been a steady plateau that may actually be now increasing, and figuring out exactly what that means in terms of protecting people, the social distancing, mask wearing, etc. These are all areas that have to be subjected to really careful research and quickly, so we can understand better what we may be seeing again, maybe in the fall or even in the summer.
Sure, sure. You know, it strikes me in what both of you have talked about, how there are such critical health systems questions and dynamics to this, both in terms of as a specific hospital and thinking about, you know, your wards, your services, how things have to be organized and the dynamics of, you know, of the specific hospital system and how critical that is to the response. as well as you said, what it looks like to be, part of this big public hospital system network and how critical that's been for figuring out how you can balance care across different settings and so on. As I was talking to medical students earlier this week and reminiscing how when I was a medical student, I had never really been exposed to health services or health systems research. I didn't have any idea that that was something you could do or really understand. I really thought about being a doctor as being a doctor for the person right in front of me, which is of course still, critical stories within this. And I know, both of you are physicians as well in that. And yet you're also both very much working at these systems levels in terms of how it shapes care. And I think that's an important thing for us to bring out in these discussions, that as our students and as the physicians we're training look to, what gives their careers meaning or what types of questions they might want to answer, there's of course the really critical ability to provide excellent care for that patient and their family who are right in front of you. But also, for some, it's critical to play a role in shaping how our systems deal with challenges, whether pandemics or crises of our social disparities of health and structural racism and other issues, on all these different bigger systems levels. I guess, so looking forward and kind of thinking along those lines, how do you think this pandemic might have lasting impact on the systems by which we deliver care here in New York City, perhaps as a starting place, but also maybe thinking across the rest of the United States as well?
Let me start with that one.
Sure, if you want, and then we'll go to Dr. Curcio.
Yeah, and then we'll take turns with that. I think
Sure.
We've learned some lessons that in retrospect seem obvious. For example, as I mentioned, we've had to close down a lot of our outpatient services. And as a result of that, we've gone to video conferencing with patients and teleconferencing, et cetera. And for many, many patients, that's perfectly adequate. And I think there could be a streamlining of our processes that stems from that. And we were leaning in that way to begin with, but this is going to accelerate that model, I think, where the routine of bringing people in every 3 months forever for a clinic visit is maybe a thing of the past for many patients. And I hope that will be true. I think in terms of medical education and training, we have to keep in mind, this is not the first epidemic like this. It's not even the first coronavirus epidemic. It's just the worst. And in terms of developing our system to deal with this, we really have to look at stockpiles, at movability of medical staff, at changing the shape and size of hospitals. I think, we got a sense from Ebola that we were very successful in the handful of cases that came to the United States. But this is what a pandemic really looks like. And there's no reason to think that we're going to be ready for everything. We just have to be prepared to be more facile, more quick on our feet.
Sure. Dr. Curcio, you want to add your ideas on that as well? Sure.
Of course, I agree with everything there. And I think that for New York City in particular and health and hospitals, there was a perceptible change in function across the system as a whole. Of course, we communicate to some extent with the other hospitals and with central office on a regular basis, but there is a lot of walls, a lot of barriers to getting things done across the system. Sometimes when you want to do something in your hospital, it has to be agreed upon. Through this process, I saw a really quick breakdown of those barriers. I was in very regular communication with the directors of medicine at the other 10 hospitals. We were sharing from day one on regular calls. what we were seeing clinically, what the volume was like, what the acuity was like, protocols that we were putting in place for how to manage as we were all guessing, and trying to figure things out, because there hadn't been real research yet. We didn't know what worked. We still don't to some extent, but we were sharing that information, those protocols. We were troubleshooting as we would see certain clinical situations arise, as we were noticing issues with thrombi, as we were seeing strokes, as we were seeing, secondary bacterial infections. That stuff was quickly shared across a large network. We were able to make changes in Epic that normally would have taken months to get order sets and new kinds of documentation in place. We were able to share equipment, something that nobody had been thinking about. We one day ran out of Shiley catheters because we were not prepared for the number of patients that were going to need emergent dialysis. So we had the machines, we were running low on dialysate, but someone came on a Friday afternoon and said, we just put in our last Shiley. So we were able to ferry them over from another hospital. So that kind of stuff was great in terms of sharing. And central office was really able to put together some communication systems that were very, very helpful. So I think those kind of barriers broke down. I think for the city in general, the recognition of the need for the public hospital services became a lot more apparent. I think people have a perception that you only go to the public hospital if that's all you can afford. In reality, when you look at H&H, we service over 1 million New Yorkers per year. That's 1 in 8. That's not only the uninsured people, right? It's a real infrastructure. So I think that we're going to see a lot of positive support, probably from the city and the state level, to enhance services for the whole system and for vulnerable populations. And I think internally, we all know that there are things we want improved, things we want enhanced, that maybe just kept getting pushed to the back for whatever reason. And I think that we're going to see a push forward in those that's going to be positive. Dr. Massey mentioned things like telehealth, video health. Those are not new concepts. We knew that we should have been moving in that direction, or we're trying to move in that direction. It's going to get a push.
Absolutely. Are there any, before we're going to move to questions next. So if you're listening and you have a question, please feel free to start typing that and adding that as we look at those. But I guess as we kind of wrap up this portion, is there anything that you would like to kind of share as a kind of, not your final message in this, but as an overall message about things we can do to keep building better health systems as a result of this experience, or kind of what not to forget or what to keep working on with this?
Go first.
Yeah. Go ahead, Joan, you start.
Okay. I think that, the really basic, the really obvious communication across the system. Nobody has the full view of what's happening. So you really need groups that are built across disciplines and across departments. You need frontline staff along with administrators to really understand what we need and how it could be done. There just has to be an openness. And I think as long as the people doing the work are allowed to innovate based on experience, and that can be heard and moderated for what's feasible, I think we have just potential to keep growing.
Sure.
Yeah, I think just to reiterate a little bit what I had said earlier, I think there has to be a concrete plan to increase hospital capacity, maybe particularly in the hospitals that serve the uninsured populations who may not have any place to go. But really all hospitals in New York were extremely hard hit by this. And remembering that this is a virus that seems to carry a mortality rate of quote unquote only 1%. That's much less than SARS carried, much less than MERS carried. If this virus turns into something worse, we will be overwhelmed. There's no question about it. And I think we have to remember this. I think there's a pattern in the U.S. healthcare system of forgetting when it takes resources to be created and maybe kept aside just in case. That doesn't get done. There's typically a 3-day supply of medications at any hospital. And obviously in a situation like this, that didn't work. So anyway, we have to keep thinking about it and not forget about this experience.
Yeah, absolutely. I think remembering and holding on to these lessons and not having that quick memory loss or amnesia that we so often do. So starting to look at some of the questions, there's one, I'll start with Dr. Curcio. It highlights the important benefit of a unified system to respond to a pandemic, namely health and hospitals in this setting, which you've both talked about throughout. Do you think this pandemic will make a single payer system more likely? So kind of getting into this question of what will we remember, what will we continue to do out of this? Any political predictions, perhaps?
I'll leave that one to you, Dr. Massey.
I think a single payer system has certain very, very clear advantages. And when we don't have that, unfortunately, the ability to pay gets tangled up in medical issues, even under circumstances like this. And I should this be an opportunity to open up that question again? Yes. Will it be? We're going to have to wait and see. Unfortunately, politics right now are so polarized that it's hard to predict exactly what will come out of this. But I think for me, this makes a strong argument for universal health care.
Sure.
I would just highlight, staying out of the national picture and just looking locally. I think we have to do more to get the message out about what is available through the city system. There is, of course, disparity in what people can pay, but this truly is a place where there is access for everybody. We do not look at people's ability to pay when they walk in the door, the services they get, the medications they're sent home with. Nothing is changed based on the ability to pay. So I think we are extremely lucky in New York City to have that. And that is not true in most of the country or even in other parts of the state necessarily. So we really do have to educate people that they can't be scared to seek care if they don't have insurance.
Yeah. I guess sort of a question that in some ways follows along the lines of thinking about logistics of still being able to seek care and what people should know, obviously recognizing a lot of things have been in flux even in the last week. What is the plan right now for outpatient care services at Elmhurst? How soon do you think those might be reopened? What precautions will be in place? How are you looking towards opening up some of those additional services again in the way that they have not been able to while the pandemic has been so intense?
I think that's going to come in stages, as it will everywhere. I'm sure they're looking at ambulatory surgery now, colonoscopies, et cetera, to arrange for those procedures to be done. I think the big challenge comes to sort of rearranging clinic space. So clinics will open sequentially, but we will never again, anytime in the near future, be able to tolerate packed waiting rooms. It's just not going to work. So we have to figure out these space issues, and we're working on that, exactly how we can stagger clinic times, et cetera. And we just have to keep working at it. If we set firm rules about contact, that's the first step, and that is happening. But this is going to be an ongoing challenge, and it's going to be, since vaccine and preventive measures against this are probably in the pretty distant future, we're going to be dealing with these issues for a while, and maybe right into the next time we're dealing with a similar problem. So I think crowding, as in all situations that this underscored, is going to be a major challenge for us, but we're working on it.
Yeah, you know, and as a pediatrician, and I know you're really aware of this as an infectious disease physician as well, you know, we are worried especially about children's immunizations right now and thinking about what that looks like moving forward. And there are many things along those lines where, yes, like we think of it as something that can wait maybe or not be as critical, and yet at the same time, it is also a critical gap to go without those vaccines that are protecting babies and often protecting along with them families from, you know, other terrible infections and problems as well. So I think it is a continual both communications and the systems question of how can we do this safely and yet have these critical services reopened in the ways that we need to keep people healthy and not make a terrible situation even worse in that regard. There are a few questions about some specific groups serving within the system and how they were responding to the pandemic. We might move to one, and this is, Dr. Massey, you commented on the devastating mental health impact among trainees especially, and I think that extrapolates across the board, the healthcare workers and also those working in our healthcare system who may not be considered healthcare workers, but of course we all know who are also essential, working at front desks and cleaning rooms and transporting patients. But specific to the trainee question, there's one about some ideas related to policy changes that might be taken to better protect trainees during pandemics, or ideas for how this might shift parts of our medical education system as well. I would expand.
Sure. Well, medical students were, of course, pulled out of this, and that was a good thing to do. I think the younger trainees, the interns and the junior residents, I think, you know, doctors have a certain standard personality, and it varies somewhat, but it's within some boundaries. And that personality is, I can deal with this. And I think many of us are reluctant to express fear and hurt, sadness, because it gets in the way of other things that we're supposed to be doing. Sure. I think if ever we were going to have that discussion opened up again, this has done it. We have seen many trainees who were clearly traumatized by this experience. And even if they don't face this experience again, it just underscores how in medicine we have not made people feel that they're hearing about their feelings is something we welcome. I think a number of hospitals in New York City, including our own, have opened areas in the hospital where people can go for counseling, and it has basically been underused here and everywhere else. And we have to find a way to encourage that, because not only for their own care, but if we don't allow young doctors to feel they can express these concerns, are they really going to be the best doctor for their patients in the future? We don't want to build in a wall that can't be bridged for anything. And now's an opportunity to try to build services. There have been certainly been efforts about this before, but this has really underscored that for me.
Sure. Dr. Curcio, do you want to add anything to that?
Yeah, I think we typically, you know, at least here, and I believe with the Sinai system, at least for medicine, we leave a lot of the day-to-day operations for the training programs to the chief residents. So they are responsible for the schedules and things that we're going to implement, change, orient, in service, all kind of flows through them. I think that that's probably not sufficient. It always worked in the day-to-day when changes could happen slowly and they could bounce things back and forth. I feel that we're going to definitely need, going forward, a much more day-to-day involved system of the program directors and the APDs, really for function. You know, people who are really in there, and if things suddenly change, obviously we hope that it'll never change like this again. But when there are changes in the system or an uptick in what they're responsible for, something that seems traumatic to deal with, we really need a higher level, quick frontline response to evaluate people. And as Dr. Massey said, we refer to services being available. I think we need a much more ready way to assess people one-on-one, which is hard because everybody had an uptick in what they were doing. It's not like anyone was sitting back with time. So we have to build in that as being part of the job and the responsibility to go and really evaluate people, not say, hey, here's a number, call it if you want to talk, but going forward and just doing on-the-spot assessments of how somebody is, some kind of a quick screening tool for how they're coping, and being able to pull people out of a situation quickly if you know that they're not coping well, and being able to direct them to help rather than suggest it. I think we're going to have to see a lot more of that.
That makes sense. Another question for you, Dr. Curcio. So, you spoke a little bit about concerns about where there may have been misperceptions in the community about what was happening. Maybe they weren't receiving enough information or full information and so on, and how that may have even made the spread worse, of course, as well. There's a question about about potentially stigma and coronavirus, and also too the calls for massive testing, and how these ideas of stigma, of massive testing efforts, of what the aftermath of that might look like, how that could particularly affect the vulnerable populations that Elmhurst is serving. And I think it maybe brings out some of those same concerns in a way, or with particular questions. I'd be curious to your thoughts about where there may be issues there and what needs to be considered as we think of ideas of testing many more people, or what this next phase looks like.
Yeah, so taking them separately, the stigma I think is real. I mean, of course, we can look for the decades-long issues that Dr. Massey still works with other countries on the stigma of HIV. We're seeing it now. I mean, we see it. People are actually just scared to be around certain populations. Early on, we saw a big turning away from the Chinese community, just out of fear that this had come from China. And obviously in Queens, there's a very large Chinese population. People were turning away from them very quickly. As time goes on, there is a sense that anybody who might work in healthcare, I've heard stories from nurses, physicians here who say their neighbors run. As they're getting out of their cars and walking to their house, they're scared to be anywhere near them. So certainly when you're looking forward to people returning to work in service industries, food services when they open up, and just general, any kind of service industry, I think people are going to be reluctant to hire populations that they think are exposed and maybe putting them at risk. I think that's going to be, an economic issue for those people. Yeah. The widespread testing, Dr. Massey can weigh in on how he feels about this. I think personally, I think a lot of the calls for the widespread testing are really creating something that is not so useful. People have this sense that, everyone should be tested, and that's when we can open things up, and that's what's going to be the future. From my perception, I don't really see the value of it. I mean, antibody testing, maybe, knowing how people are doing for the longer run. But when you're testing a population and then saying they're okay, that doesn't mean they're okay. The exposure is continuous. Sure. but I think we may again see, I can already see the lines picking up outside the hospital again. I am seeing these populations. Again, it is our local, primarily minority population who's showing up and standing online outside the hospital to get tested because they're getting the perception that that's how things are going to move forward.
Right, right. Dr. Massey, anything you want to add to that as you think about the community and how these issues might play out?
Yeah, I think since our community does have a lot of crowded living facilities, I think the role of antigen testing will come under sharper focus. There'll be strategies where in certain communities, it makes a lot of sense to see how many people in that community are currently infected. One of the amazing things that we found during this was how often pregnant women with no symptoms turned out to be antigen positive.
Yeah.
It was just astonishing. And as hopefully this acute outbreak moves out of New York, that may be a role even for antigen testing. The problem, of course, with antibody testing is nobody knows exactly what to make of it. It's too early to say it means you're immune.
Sure.
We've had discordant results already. There are a variety of different companies marketing these tests. They're all over the place. And hopefully within the next few months, it'll focus on clear strategies for using these tools. But I do think that working out regional potential hotspots will be one use, at least for antigen testing.
Absolutely. Well, I think we're going to have to wrap up our time together here. First, as we close, let me just again thank both of you for spending this time with us today. I know and can only imagine the extent of the clinical and mental and emotional burden that these weeks have taken, and we really appreciate taking this hour to spend time discussing all of this. It's really helpful for all of us in considering a bigger picture and especially the way forward based on these important stories and lessons that have been so hard won in your work at Elmhurst. So thank you on behalf of all of us. I do want to note that this session has been recorded and it will be posted for anyone who would like to see on YouTube. We typically have them posted by the next day. So if you look to the Arnhold Institute site, and we'll also recirculate it with the distribution lists that go forward, feel free to send people that way if anyone's interested in seeing the recording as well. Next week, our session is going to be looking at nursing perspectives on fighting the COVID pandemic, and that will be, I think, another excellent set of discussions and questions and getting a glimpse into a different part of the system a little bit more as well, and what that looks like, including global participants. So again, thank you for your time. We really appreciate it. And thanks everyone who's joined us today.
Thank you all very much.